And with the standard statement, I have nothing to declare, I received no benefit from creating this video, and I was not bribed to keep it short. My topic today is NM610, NM622, and NM630, the technologist's perspective. As I am ending my career, I reflect on things that have become obsolete, that were everyday products that everybody used, and no one in the younger generation has any idea what they are. Some of the older people, like Tony, Wayne, Abraham, and of course Dr. Stocker, will remember some of these products. Hopefully they'll sit back and smile as people try to guess what they were. The first item I'm going to discuss is this object that you see on the screen. In the 50s and 60s, every child in the United States owned or had access to one of these and used it regularly. What is it? It is a skate key used to adjust and put on your roller skates. This is what an old pair of roller skates used to look like. It had a leather strap to hold it onto your ankles, and underneath the roller skate there was a little nut that the key would unlock. This would allow the skate to telescope out, and you could fit it to the length of your shoe. After adjusting for length, you then would step into it, and the nut in the front would screw down. The two little wings you see at the tip would pinch down, and they would clamp onto the sole of your shoe. This allowed them to stay on, and then you skated. God forbid that you were ever caught by your parents using your good Sunday shoes for this. The first topic will be NM610, cisternography. An informed consent must be obtained as part of patient preparation. This is done by the physician who is performing the lumbar puncture. It is also best to tell the physician who is doing the lumbar puncture to also bring their own lumbar tray. The radiopharmaceutical that we use is indium DTPA. The dose is 500 microcuries. An outside physician will perform the lumbar puncture. It is then the authorized user, be it a technologist or one of the physicians of nuclear medicine, will connect the syringe to the needle. They will slowly inject, and then they will flush the syringe at least 3 times with cerebrospinal fluid to make sure the entire dose is in. The person performing the injection will then pull the needle straight out after flushing. Do not attempt to disconnect the syringe and reinsert the stylet. If this happens, there will be dripping, there will be contamination, and you have spots on your image that you don't want there. Then after the injection, be sure to ask the physician what their preference is in keeping the patient supine. Some will say, do it for 20 minutes. Some will say, do it for 2 hours. Others will say, it don't matter. Just let them get up and walk around. For the imaging, be sure that you have installed the medium energy collimator, since this is indium, and shortly after the injection, you would take a posterior image that is required for 10 minutes or 250K, whichever happens first. This is an image to determine whether or not the injection was good or not. This is an example of a good injection and a bad injection. On the left, it is a bad injection. You see soft tissues. You see kidneys. You should not see this on early images. And you see coming off from the column these little legs, which are actually the nerve roots, it gives the impression that you're looking at a centipede. This is called a centipede sign. On the right, you see that the isotope is confined to the space. You see no soft tissue, and you do not see any little legs coming off the column. This is a good injection. Imaging happens at 4, 6, 24, 48, and in very rare cases, 72 hours. Anterior, posterior, and then right and left lateral images are required dual head for 10 minutes, 250K, whichever happens first. And this is an example of your 4 images. Our next obsolete item is this little gadget here. Just about every American home had dozens of these things laying around in the 50s up to the 80s. Any idea what it is? Well, if you had a 45, and for you younger people, it played music, and your record player was one of these, where the center of the turntable was a small spindle, and you did not have a record player that had a 45 adapter, you would pop one of these into the center, and you were then able to play your record on a spindle type record player. This next item was used by high school kids, college students, and was used by people who were in technical fields. It was popular until the mid-70s, until calculators came out. What is it? It is a slide ruler. It was used by sliding the middle number, and using the slide, you lined up numbers, you slid the center. This allowed you to multiply and divide big numbers quickly without having to use pen and paper. And if you had a nice and expensive slide ruler, if you flipped it over, you were able to do logarithms. The next topic is NM622, ventricular shunt studies. As part of patient preparation, when scheduling, identify what type of shunt it is and have it documented on the OD sheet, and also identify what physician is going to be placing the needle, and this needs to be determined prior to scheduling. The radiopharmaceutical is technetium DTPA, and the dose is 1 millicurie in the smallest volume you can get. The administration technique depends upon what type of shunt reservoir you are using. The needle is placed by the neurosurgeon, and the dose is injected by the authorized user. If it is a reservoir that requires pumping, the neurologist will have to stay around until the study is complete, in case pumping is required. With this procedure, we just use our normal technetium windows and collimator. The SOP says to acquire dynamic images of the head and neck, 10 seconds a frame for 5 minutes. Then acquire anterior images of the head and the entire distal length of the shunt at 5, 10, 20, and 30 minutes, or until you see the radiopharmaceutical empty into the peritoneum or heart. At the end of 30 minutes, if it's not visualized, You may be asked to do additional spots at 1 minute each. You will display the spots so that the background is just visible, and you may be requested to do a hemi-body from the head down to the mid-abdomen. Okay, having said what was in the protocol manual, for the dozen or so that I did at the old Walter Reed, what we actually did was after the neurosurgeon injected and pumped, we did a picture of the head, a picture of the chest, and then pictures of the abdomen. And we continued to do pictures of the abdomen until we saw the radiopharmaceutical spill over, or until the OD said, okay, this isn't going to happen, stop. This is a rendering of what we are doing. On the upper side, you see one end of the shunt is in the ventricle, and the distal end is just hanging free in the abdomen. The injection happens behind the ear or just above the ear into a shunt reservoir. This is what the reservoir looks like. And these series of images show the injection and free flow into the abdomen until it spills over and the study is done. Up to the mid-70s, before CT and ultrasound existed, this is a Sweets localizer. I am probably the only person who remembers what this device was used for, and in my younger days, I was considered to be the king of the Sweet localizer, as it always fell when I was on call. What is it? The Sweets localizer was used for finding foreign bodies in the orbit. You have to remember that back in the day when there was no CT or ultrasound, there was no way to internally look into the eyeball unless you actually cut it open to try and find the foreign body. This could be quite invasive. If the surgeon had an idea where the foreign body was, trauma to the eyeball while removing the foreign body was lessened. The radiologist would use the radiographs produced by the technologist and doing calculations due to angles and position, again using a slide ruler since there were no calculators. He was able to extrapolate and plot on a chart the approximate location of the foreign body. In its time, this was a highly technical procedure, and very few radiologists could perform it. The second device that I'm going to be bringing up for radiology was used quite extensively before we had ultrasound. What is it? The device was called a pelvimeter. It had graduations in it that could be seen on a radiograph. It was placed at the level of the symphysis on the lateral and on the anterior, and radiographs were taken. For those of you who are x-ray techs, you had to use lumbar spine technique, and it was quite a hefty dose to the fetus. You preferably would only do one radiograph in each one and pray that you did not have a repeat. This procedure was usually done on women who had a vertex head down position but were unable after hours of labor to deliver the child. These women were exhausted and they were not in the best of moods. This was a difficult procedure to perform because in most cases the patient was not able to cooperate. This is an example of the lateral radiograph, and the arrow indicates the ruler that you could see. You can see the baby's head, the coccyx, the symphysis, the rami, all the important points that you needed on the radiograph. The end result were calculations of whether or not the pelvic outlet was going to be large enough for a baby's head to pass through. Some women are too narrow, and unfortunately this isn't found out until after they've had multiple hours of labor. They go on to have a C-section if the outlet is too small. The next and last topic is NM630, CSF leak, or the Pledget study. The only true preparation for this patient is coordination of the multiple services. The nuclear medicine physician, the floor supervisor, the ENT staff, and the radiopharmacy must all be together on this procedure, and until everybody has had a chance to have input and has been notified of what they need to do, the procedure cannot be scheduled. The radiopharmaceutical is indium DTPA, and the dose is 500 mics. Set the camera up for a medium energy collimator. An outside physician performs the lumbar puncture, and the authorized user, be it a technologist or a physician, does the injection, being sure to flush fluid 3 times at a minimum, and they pull the needle straight out. Informed consent must be obtained by the physician performing the lumbar puncture. The physician must bring his own lumbar puncture tray. The pledgets must be obtained and weighed the day before, and the pledgets are placed by the ENT. The pledgets are approximately 1 centimeter by 1 centimeter, and the other characteristics are here on the slide. The patient reports to ENT and has the pledgets inserted. They then come to nuclear medicine. One of the first things we do is we draw a background blood sample of 5 mAs of venous blood. The pharmaceutical is introduced into the lumbar spine. And 18 to 24 hours later, the pledgets are removed, are placed in test tubes, and are labeled as to where their location was, and another 5 ml sample of blood is withdrawn. The blood is centrifuged down, and a volume is taken out of the plasma and is counted, as are the pledgets. The activity on each pledget and the activity of the blood plasma is counted in a well counter, and a ratio of radioactivity of the pledgets over the average plasma radioactivity is calculated, and the normal result is displayed. Imaging is performed with a medium energy collimator at indium windows. As for imaging, a posterior spot of the injection site is performed to see if the injection was good. Then you do delayed anterior, posterior, right lateral, and left lateral images at 2, 4 to 6, and 24 hours. Delayed images up to 48 to 72 hours may be performed. The laterals are done using a transmission source, and you acquire the images for 10 minutes or 250K, whichever happens first. Here are 2 examples of a positive study. On the left, you have a nasal leak where the arrow is pointing, and the image on the right, there is an ear leak, as indicated where the arrow is. Leaks do not always happen from the nose or ear. They can actually happen anywhere along the column of radioactivity. Because of this, it is always a good idea to perform in the later images at least 1 hemibody from the top of the head through the bladder to see if there's any leaks. We call this the stack view. In the 50s, 60s, and in your backward areas, mid-70s, every male used one of these. What is it? It is a single-sided razor blade dispenser. The little pointy out part, the little metal part, you pushed the old razor blade out, and you can see on the top there is a thumb slide. You would then slide the new razor blade into position. It was like a safety razor, but it only had one side. This device was a short-lived fad that was used only by women. What is it, and what was it used for? It was called the epilating. The coils would rotate. The lady would rub them up and down her body wherever she wanted hair removed. The coils would catch the hair and literally rip the hair out by the roots. It was quite brutal. It did, however, leave a stubble-free skin, and it lasted for probably a few weeks. And finally, my last item. On the back of medicine cabinets and in affluent houses, in ceramic tile, there were these little slots. What were they used for? The little slots were used to actually dispose of razor blades. You would insert them in the slot, and then they would fall into the wall between the studs. If you ever refinish a bathroom from the 50s, 60s, and 70s, be careful. You will find this in the walls. The products and procedures of the olden days, to some of you younger techs, were day-to-day products, and we had no idea that they were eventually going to be replaced. You too, in 20 to 30 years, can tell people about file rooms that had actual paper and actual images that you held. Maps that were on paper, not on a screen. CDs and DVDs. Why would you even consider using that? Film processors. The inefficiency of written news on paper and writing letters and putting them in the mail and sending bills through the mail that took 3 or 4, 5 days to get to their sender, all of these too will be obsolete. And I am happy to say that this is probably going to be my last presentation that I ever have to give before I retire.